Okay, A&P folks, this is the third time I'm trying to get the second part of the desktop working so that you can see my slides. Hopefully we're going to work on it this time around. Okay, keep your fingers crossed. Here is my PowerPoint. We are actually going to start by backtracking a little bit with the cardiac cycle itself, because people were a little confused on that. So we're going to review what we're doing with the cardiac cycle before we go onward once more. The big thing to remember is that the cardiac cycle includes the events that are associated with one heartbeat. So this is going to be, whoops, maybe I can get my pen working right, and maybe not, okay? These are all of the events associated with one heartbeat. So when we are looking at contraction and relaxation of my atria and my ventricles, this is my depolarization and repolarization event for muscle contraction. What you'll notice is that the contraction, which is called systole, and the relaxation or the diastole of both my atria occur as one. And this is due to those gap junctions that we have as far as the histology of muscle tissue is concerned. Then we are followed by a delay. We have a delay in the delivery of the action potential. And then both my ventricles are going to contract. So when I take a look at these electrical events, there's some things that we want to remember. Remember that contractions and relaxation of any muscle is tied to depolarization and repolarization. Of your heart muscle. Okay? The source of the electrical activity are specialized cardiac cells, or cardiac fibers rather, that are called autorhythmic fibers, okay? And these autorhythmic fibers are self-excitable. And they generate the action potential. Remember, we have to hit threshold level before we can go any further. And of course, the resting membrane potential of cardiac muscle is a little higher than what we saw for skeletal. This one is actually about minus, the resting membrane potential is about minus 90 millivolts. Okay? So the action potential is the thing that will end up triggering the contraction. And so this is your pacemaker. What you want to be able to do is to trace this wave of depolarization. It's also called the conduction system of the heart. You have an interactive video that will talk you through it, but I will write down some notes for you to sort of help you make sense before you look at that video. Remember, the videos are on the PowerPoints themselves. You do have to be connected to the internet in order to see them. So what's going to happen here is that we are going to begin in the SA node. SA stands for sinoatrial node. It is in your right atrium. The wave of depolarization is going to spread very rapidly to both atria. Okay, so the depolarization wave spreads rapidly to both atria. So both atria are going to pump as one, okay? And that is due to gap junctions. So your atria are going to beat as one. Then we're also sending a depolarization wave to the AV node, which stands for atrioventricular. So it's between the atria and the ventricles in the septum. And this is where the depolarization, the action potential slows. So this is where the action potential slows. The reason we want it to slow is because we don't want your ventricles to contract while your atria are contracting, because we want to dump all of the blood from the atria into the ventricles. So it allows me to have some time and a place to put my blood. From the AV node, okay, from the AV node, I travel to the AV bundle. From the AV bundle, I go to my right and the left bundle fibers. Okay, down the septum, okay, to my large diameter Purkinje fibers. At which point then both ventricles contract together. So it's important that both my atria contract together, then I have a pause, and then both my ventricles will contract. So when my atria contract, I'm going to send blood into the ventricles. When my ventricles contract, I'm sending the blood to my different arteries. Okay, I hope that makes a little bit more sense than what we had. That cardiac cycle is written out for you, I think, pretty nicely in this interactive video. So what I have is my atria contract as one. And then I'm going to have a delay. And the delay is because of the different size diameters that I have for my nerve fibers. my delay will allow the blood from the atria to flow into relaxed ventricles. Okay? And then after my ventricles are full of blood, then they contract as one, and therefore then blood is going to go into arteries. The big thing to remember is that veins return blood to the heart at the atrium. Okay, the ventricles are attached to arteries, and they are either going to go to the systemic circulatory system or the pulmonary circulatory system. At the end of this chapter, you guys should be able to compare and contrast right side, left side of the heart, as well as systemic versus pulmonary circulation. Now, the other thing to remember is that if you are contracting, you are going to be increasing pressure. And we'll look at that in a moment, okay? These electrical events are associated with atrial systole, meaning this is contraction, okay? And diastole is relaxation. And so we can see this on an EKG or ECG tracing. So what are you going to do is you're going to have both atria contract, then relax, then you're going to contract your ventricles, and then you're going to have a 4/10 of a second relaxation period before the atria do it again. We're also going to see that every time we contract, we create pressure. So each cycle, my atria and my ventricles are going to alternately contract and relax to force blood to flow one way. What helps us do it one way are the different valves. So for each cycle, my atria and the ventricles alternate, okay? They alternately contract and relax. When they contract, we increase pressure, okay? So contraction increases pressure, and that pressure drives blood one way. Okay, the presence of valves ensure one way. Okay, AV valves for between the atria and the ventricles, semilunar valves from the ventricles to the arteries. Now, what you're looking at here is we are looking at your systemic system. So this is necessarily the left side of your heart. we have different pressures on each side of the heart. Remember, the right side of the heart feeds your lungs, or the pulmonary side. So the right side of your heart goes to the pulmonary circulation. We are looking at lower pressure. We have to build up enough pressure to overcome the pressures that we already have in the pulmonary trunk. And that's only about 20 milligrams, millimeters of mercury. The left side of your heart is servicing the systemic circulatory system, and we are driving blood to the entire rest of your body. So the pressure is higher here because we have to go further. Okay? We have to get to about 120 millimeters of mercury. Okay? Generally, we have to get at least above 80 millimeters of mercury to open the aortic semilunar valve. You can tell that the left side of the heart has more pressure because the muscle is thicker. So we have a harder pump there, if you will. Both sides, the pulmonary artery and the aorta, are receiving equal volumes of blood. It's just the pressure that is different. So both the aorta and the semilunar, and the pulmonary trunk receive the same volume of blood. We're looking at about 70 milliliters of blood. But the pressures are different. Why? Because the right side of the heart is going right to the lungs, which is pretty local. Each ventricle can hold about 130 mils of blood at the end of relaxation, but it's only delivering 70 mils of blood into each artery. Okay, the sounds of the heart that you hear when you're doing auscultation. Are your valves opening and closing? Okay, this graph shows you that at the end of relaxation, each ventricle holds about 130 mils of blood, okay? What is your stroke volume? Your stroke volume is the amount of blood that is ejected with each contraction, okay? And you'll notice that we're only pumping out something on the order of 60 to 70 mils, okay? So your stroke volume is the amount of blood ejected with each ventricular contraction. Okay, and we're looking at about 70 mils. End systolic volume, okay, is what's left in the ventricles after a contraction. Which we're looking at about 60 mils. Okay? My total volume is 130 mils. We do not want to wring the ventricles dry because it's too hard to open it up again. So we always have a reserve. Okay, so when you're looking at the mechanical events, you want to take a look at the phases of the cardiac cycle and what each one of the contractions and the different valves are concerned. Okay, this actually is taken right out of your book. It's a really nice way of matching up pressures, sounds, and volumes with the different phases. Okay, we did not cover cardiac output the last time or with part A. Cardiac output is actually the volume of blood that is ejected from your ventricles into the arteries, either artery, each minute. Remember, equal volumes in each of the pulmonary artery as well as the systemic artery. So both ventricles pump equal amounts of blood into their respective arteries. Okay, so your cardiac output is equal to your stroke volume. Here we're looking at about 70 mils times the heart rate. Normal heart rate, we're looking at 75 beats per minute. And that's going to equal somewhere in the order of 5.25 liters of blood being pumped with each cardiac cycle per minute. Of course, that can change depending on circumstances. The factors that regulate stroke volume include things like preload. Preload is your degree of stretch. Okay, that can increase the force of contraction. This is also known as the Frank-Starling law. Of the heart. Okay? Contractility is the forcefulness of the contraction. And we do have different agents that will increase or decrease the forcefulness of the contraction, which increases pressure, which drives your blood flow. Okay? We do have agents that will increase calcium, for instance. They are called inotropic agents. So inotropic agents increase calcium. Remember, calcium is a very necessary ingredient for both striated and heart muscle contraction, also for non-striated, if you will, or smooth muscle, but especially for the heart, because the heart has to increase or import calcium from the interstitial fluid. Other things that will increase contractility, so these things will increase contractility. Another thing that will increase contractility are the hormones epinephrine and norepinephrine. And of course, things like digitalis. Okay, decreasing contractility can be caused by an increase of potassium, things like acidosis. Now we're looking at pH changes here. We're looking at anesthetics. If I can spell that, anesthetics. And things like calcium channel blockers. So many drugs that are used to adjust blood pressures are classified as calcium channel blockers. What you're doing is preventing calcium from getting in, so you have a weaker contraction, if you will. Afterload is the ejection of blood from the heart. All right, we are looking at pressure that must be overcome before the semilunar valves open. So an increase in afterload causes your stroke volume to decrease. So more blood remains in your ventricles. Here we're looking at things like hypertension, and arteriosclerosis, arteriosclerosis. Okay, so when we're looking at the autonomic nervous system here, one of the things that we have to remember in terms of regulating the heartbeat is the cardiovascular center in the medulla oblongata. And if you remember about the nervous system, one of the things that we had were lots of receptors coming from all over your body that are fed into the center to analyze and control your heartbeat. Among the things here, we have our proprioceptors, we have chemoreceptors, and we have baroreceptors. Baroreceptors are pressure receptors. And don't forget, we also have the vagus nerve, which is one of your cranial nerves that is known as the wanderer and goes throughout your body. With the hormones, we're looking at things like epinephrine, norepinephrine. We can even look at the thyroid hormones. With ions, we're always worried about potassiums. We're worried about calcium. We're worried about sodium. Potassium or sodium decrease heart rate, and excess sodium blocks calcium, which decreases your contraction. these other factors also play a role in how well or what your heart rate is going to be. Age, gender, physical fitness, and temperature. This actually summarizes for you the different inputs to the cardiovascular center that is analyzing all the information about your body and affecting heart rate. And then you can see what the output of that is going to result in. We are looking at depolarization, contractility, and spontaneous depolarization of the SA nerve. This one is taken right out of your book as well. This is also taken right from your book. It does a really nice summary of tying in all of the factors that increase cardiac output and what it does. So make it easy for yourself. Anytime you have something this complex, if you can find a diagram or a chart that summarizes things for you, you need to go for it. All right, regular aerobic exercise can increase your cardiac output, increase your HDLs, high density lipoproteins, decrease triglycerides. What we're looking at in terms of HDLs and triglycerides is the ability to be blocking those arteries, arteriosclerosis. Remember, when that happens, we are increasing viscosity and then, of course, pressures that are involved with that. Lung function, we are looking at the proper amount of oxygen and that is going to be able to be delivered to your bodies. Okay? And of course, it assists in weight control. One of the things that we're worried about here is that for every pound of fat that you put on is going to be translated into something like 200 miles of blood vessels to feed it. The reason for that is that every cell in your body has to be diffusional distance away from its blood supply, its nutrient supply, its oxygen supply. And so this is going to play a big role to this whole idea of resistance to flow. It's very carefully tied to the diameter of your blood vessels, the viscosity of your blood, and the total distance that you have to deliver that blood to. So 200 miles is adding quite a bit of distance. This is one of the reasons why obese people very often also have high blood pressures. Okay, the rest of these pictures actually gives you some idea on what to do for failing hearts and a direct result of that, the different devices that we can do to unblock arteries, etc. You want to read it pretty carefully. Okay? We are not going to go into the development of the heart. I am not going to ask any questions on the lecture exam as far as the overall anatomy and the developmental anatomy of the heart is concerned. The back colored pages of your textbook does cover homeostatic imbalances. You pretty much want to read them very quickly and be able to define them. I want to go back one more because I have a blank slide here. I need a blank slide. I want to make some very quick tips for studying for the lecture exam. Some of the things that you need to remember: we love compare and contrast. So you, at this point, for this chapter, you want to compare and contrast right side versus left side of the heart. You want to be able to compare and contrast systemic versus pulmonary circulation. What else can we do? A lot of definitions in here. You want to be able to trace the path of blood. Throughout the heart. Okay, keep in mind that you're looking at the blood vessels, you're looking at valves that are involved, and then where it's going in terms of the chambers of the heart. So you really need to know the overall anatomy of the heart and be able to label both the real deal as well as the pictures from your textbook. Okay? So some of the generalities that you should remember is that veins attach to atria. Okay? It does depend upon what side you're on. Okay? Right side or left side, it's both a vein. For the right side of the heart, you're looking at your systemic veins. And they are deoxygenated. The systemic veins are your vena cava and the coronary sinus. So here you have two vena cavas as well as the coronary sinus. For the left side of the heart, you're looking at the pulmonary veins. We have 4 pulmonary veins. And of course, they are oxygenated blood. The other thing to remember is that arteries attach to ventricles. Okay, so your right ventricle to the pulmonary trunk, and it's deoxygenated. Okay, the left ventricle, you're looking at the aorta. And of course, that one is oxygenated. Remember your valves. You have a set of AV valves. The right AV valve is also known as your tricuspid. The left AV valve, we use the mnemonic LAMB, L-A-M-B, which stands for left AV mitral bicuspid valve. All of those names are the same thing. And then, of course, we have the semilunar valves, which are between your ventricles and your arteries. So we have a pulmonary as well as an aortic semilunar valve. Okay, keep in mind the volume of blood that is pumped into each of the arteries from the ventricles is the same. Okay, but the pressures are different. we have higher pressure in the left ventricle and the aorta, and therefore the aorta, than the right side. And the reason for that is that the left side is responsible for pumping all of that blood to the entire body, whereas the right side of the heart is only dealing with delivering directly to the lungs. So it's pretty local. All right, so we are done with chapter 20. The next thing that we're going to work on for next week is going to be chapter 21. In the meantime, people ought to be working through the cardiovascular system of the heart itself. We are doing blood this week for you guys in your lab, and by next week, you will be looking at the heart itself, and then the following week, cardiovascular physiology. Those of you that have done the blood lab already, several people have asked us about looking at them and saving those slides. Bring them on in. We will certainly load it up into a microscope for you guys to take a look at and see the real deal. I think it's really ooh-ah. So again, if you guys have any questions, please email us, come and see us. I was very pleased to see the results on your quizzes. Keep up the good work.